Hello, and welcome to Hollings Crosstalk. I'm Dr. Andre Abbott, a cancer surgeon at MUSC Hollings Cancer Center. Today, I'm talking with two individuals who are very involved in helping people to quit smoking and to get screened for lung cancer. Dr. Jennifer Dane, a clinical psychologist who researches ways to improve smoking cessation programs and who is also co-director of MUSC's Remote and Virtual Trials Program. And Dr. Nicole Tanner, a pulmonary and critical care doctor who is the co-director of the lung cancer screening program. Thank you both for being here today. I want to step away from lung cancer for just a minute because I think people may not realize how many other types of cancer actually are associated with smoking. So Dr. Tanner, can you speak to that?
Sure. So I think the first thing that comes to mind with smoking cigarettes is, that it causes lung cancer, as you mentioned. But I think what a lot of folks don't really know is that it is the cause of a lot of cancers, including bladder cancers, certain head and neck cancers, tonsillar cancers, stomach cancers. And in some ways, it's related to many of the cancers that folks have that we commonly see.
And of course, the big one that you said, lung cancer. Unfortunately, lung cancer is the #1 cause of cancer deaths in the United States, meaning that more people will die of lung cancer than any other type of cancer. So one way that we can potentially reduce those deaths is through screening, right? Detecting lung cancer earlier. So can you explain how lung cancer screening works?
Sure. So lung cancer screening is a very simple test as it relates to tests. It's a low-dose CT scan where the individual who is deemed eligible will come in and lay on a bed, and then they go through a donut, essentially. And this donut will take pictures, very thin slices of the lungs as it goes through, and then the interpreting radiologist will take a look and try to see if there are any small nodules that could potentially be a cancer. And so that's the actual action of doing the test. It doesn't take very long. But before we invite folks to undergo lung cancer screening, one of the most important things we want to do is ensure that they understand that there are benefits to having screened and risks. And so prior to that, either your physician or the screening coordinator as part of the program you go to will kind of outline what the benefits are of screening. And that's certainly a mortality benefit. And the potential risks, so that folks understand that there is a likely chance that we'll find a nodule, but the nodule doesn't necessarily mean cancer. And so we want people to know that up front so they're not completely alarmed when they get their results. And so the one other important thing to mention is that lung cancer screening is not a one-time scan. You have to be sure to come back every year because the majority of cancers are not really found on that first scan. They're found on scans 2 and 3. And so as long as someone continues to be eligible, we want them to come back every year. And that's really, really important to stress because it's not the same as other cancer screening tests.
Right. So what I'm hearing is screening is non-invasive. You don't get poked. There's nothing that they're looking, to put in your body. It's a CT scan and it takes maybe 20 minutes or less.
Yeah, probably less. Yeah.
Okay. So screening is part of reducing the cancer deaths, but maybe an even better way than detecting early is prevention. And
Absolutely.
And prevention could be maybe stopping smoking. So Dr. Dane, you focus on developing technology that will help intervene to help people stop smoking. And I understand you have 2 grants. Congratulations. That's tremendous. And you'll be testing how maybe electronic visits invite people to stop smoking and how that interaction might help for people who live far away from an academic health center. So tell us, what's your work and how is that?
Yeah, absolutely. So, as we've been talking about today, lung screening is one key component of prevention, and another, given that smoking cigarettes is a key risk factor for the development of all sorts of cancers, is of course quitting smoking. And so the goal, especially with these 2 grants, but with work that a number of investigators are doing here within our tobacco treatment program, is really to think about how do we extend access to high quality evidence-based smoking cessation treatment. And so with these 2 new grants from the National Cancer Institute, what we are trying to do is ensure that all of our patients here at MUSC who are smoking cigarettes are at least offered smoking cessation treatment. And so we're doing that by leveraging data that's available within our electronic health record system. And so, probably most of us, if we're MUSC patients or any MUSC patients, have been screened for cigarette smoking at the last time that we had a visit with our provider. And so all of those data are entered into our electronic health record system. And we can use those data to try to identify our patients here at MUSC that are smoking, to then proactively reach out to them with an offer to initiate smoking cessation treatment. The goal with this work is really to connect this treatment back to our own primary care and family medicine and internal medicine practices here at MUSC in Charleston, but also throughout the regional health network. So the most recent grant that we received is in partnership with 7 of our primary care and family medicine clinics that are part of the regional health network and are located within quite rural parts of the state. Because as you would imagine, there's kind of this very clear disparity in terms of smoking rates are higher among residents of rural parts of our state, and then they have these access barriers to getting high quality smoking cessation treatment. And we're trying to kind of address some of those barriers by offering this more telehealth facilitated approach to smoking cessation treatment within their own primary care practices.
Well, that sounds exciting.
I think so too.
That's great. Congratulations on that work. As you pointed out, we are an NCI designated cancer center. And so because of that, Hollings is charged with going, beyond just treating cancer, but addressing public health concerns. And so our mission is working toward new treatment, conducting research, and then helping people live overall healthier lives. So to let people know about the latest recommendations for their health, I think we know in the media, we do a great job, right, of hearing about mammograms and colonoscopy. But to your point, I'm not sure we're there yet with lung cancer screening. And I certainly would not have known that people should be screened every year. So Dr. Tanner, you just published some research along with Dr. Gerard Silvestri, one of our lung cancer doctors here, showing like who's getting screened and when. Can you tell us about that work, what you found?
Sure. So we did an analysis of the first 1 million people that underwent lung cancer screening in the United States, utilizing the data that was required to be submitted to the American College of Radiology database. So essentially, to get reimbursed for lung screening, those sites doing it have to submit information to this ACR registry. And we went back and took a look at what the first million folks screened in the United States looked like, demographically, age-wise, insurance-wise. And also took a look at their adherence, like how likely were they to come back. And so the take-home findings were the majority of individuals who were screened in the United States actually did in fact meet eligibility criteria, so we weren't screening the wrong people, which is good. We also found that many of the folks who got screened were of Medicare age, and I think that speaks to coverage. And so what we know is that folks that are uninsured or underinsured are less likely to have access to primary care, which is usually the conduit to all screening services. And so what we did find is that once folks were insured in that Medicare age, that the rate of screening was much higher than those in the younger ages. And so we also found that we were screening current and former individuals who smoked alike. And so it was fascinating, but I think the real take-home message, and something I kind of alluded to at the beginning, is that those folks coming back, the adherence rate in that group was incredibly low. Like not even 25% of individuals. Now there's certainly some flaws with the data in that maybe there was some underreporting about who came back to undergo their subsequent lung cancer screenings. But really you lose that mortality benefit. If you don't come back every year, you're not going to realize that benefit. So I think that's some important findings from that first million folks that were screened. Similarly, we've done other work in the past looking at individuals who have been screened and also managed to stop smoking cigarettes. And so while we can screen you until you're no longer eligible, if you're able to successfully encourage someone to stop smoking cigarettes, the mortality benefit of screening goes up exponentially. So you really get a better bang for your mortality buck if you can both stop smoking cigarettes and undergo low-dose cancer screening.
So I wanted to pause and just go over really quickly, because we haven't done this yet for screening. You mentioned eligibility criteria. So would you just walk me through who should be getting that screening?
Sure. So the U.S. Preventative Services Task Force is this big group of individuals that put together guidelines for screening. And so most recently, they have updated their age and smoking criteria. So eligibility for lung cancer screening is done in those that are considered high risk for developing the disease, as defined by age, 50 to 80, with a smoking history that equals at least 20 pack years. So if you are someone who has smoked cigarettes for 20 years at a pack a day, 20 times 1 is 20, so that's 20 pack years. If you're someone who has smoked for 15 years, and 2 packs a day, 2 times 15 will get you to 30, so that puts you at the eligibility criteria. And then if you're someone who stopped smoking cigarettes, first, congratulations, and second, you're still eligible because the risk is still there. And so according to the task force guidelines, we should screen folks that have quit smoking as long as they have a 20-pack year history up until they quit 15 years total. And so those are the main eligibility criteria. And I think one of the ones that's very important for folks to understand is that you do a screening test to find something early when someone's asymptomatic. So we wouldn't want to do a screening test in someone who was having active symptoms of lung cancer, like coughing up blood or having weight loss that was unintentional. If you're having symptoms like that, you probably need to get checked out and have a more diagnostic workup. So we want to screen people who are asymptomatic and otherwise healthy enough to undergo curative surgery if they have a screen-detected cancer. And that's kind of a nuance that is a little bit hard to understand, but we want to look at life years gained from screening. And so if someone has competing causes of death, for example, very bad heart failure or very severe emphysema that's debilitating, they might not be the best candidate for screening. And so that's a lot to unpack. So we tell folks just go based on age and smoking history and let your provider or the screening program kind of help you understand the other nuances to screening.
So is it fair to say if you are a smoker or you've ever been a smoker, it's probably fine just to ask your primary care doctor, should I be getting screened?
150%.
What if someone doesn't have a primary care provider? What should they do?
So you can self-refer, actually. And so there are many lung cancer screening programs that are comprehensive, especially across the MUSC Health Network and the regional healthcare networks. And there's a telephone number you could simply call and talk to someone on the other line, and they'll assess your eligibility and get you set up for one of those shared decision-making visits that I mentioned. And I should note, just to kind of speak to access, that oftentimes this conversation about the risks and benefits of screening can happen via telehealth or even over the phone. And we know that there's good patient satisfaction with, either having a face-to-face versus one of these more telephone or telehealth related conversations, so that you don't have to take a huge chunk out of your time, 10-15 minutes to understand what lung cancer screening is, and even better to understand your individual risk for developing cancer. And so that's something that our coordinators will do, is walk you through what your risk of developing cancer is based on who you are as a person. And it's a nice little algorithm that spits out a number and can kind of give you some ideas. So it's a really good exercise.
That's great. It sounds highly feasible.
Yeah, I think so.
Awesome. So one population that I know you've been also trained to reach out to is the veteran population, and that you've been working with the VA facilities here in South Carolina, Alabama, Georgia, to improve access for veterans. So how's that going?
Thanks for asking. It's something I'm really proud of. And so for veterans who receive their care from the Veterans Healthcare Administration, it's a really exciting time. We know that veterans are at higher risk for developing lung cancer than the general population because of the higher prevalence of smoking. These guys were given cigarettes in their ration packs, and also through other exposures, burn pit exposures and things like that. And so there's a real want nationally, if you look at the White House and the Cancer Moonshot, to reduce mortality from all cancers in the next 25 years. And so they're really going for the gusto with the #1 cancer killer, lung cancer. And so there is an initiative nationally called the Lung Precision Oncology Program, which is setting up centers of lung cancer screening excellence in a hub and spoke. And we here in Charleston have been named the hub for our Southeastern VISN, which is the Georgia, Alabama, and South Carolina. And so we've spent the past 18 months really putting in the infrastructure to facilitate lung screening for our veteran population, and are quickly moving across the Southeast to try to make screening more accessible to our eligible veterans. So I'm proud to say I think it's going really well. We're seeing a stage shift in those individuals screened, meaning we're catching the cancers earlier, which is a great feeling. and we're really being able to offer screening to more and more veterans every day. So I'm excited about that. Thanks for asking.
Yeah, so, that brings up something in my mind is the stigma around smoking and maybe the fear that people have of admitting that they're a smoker. Socially, it's becoming maybe less and less acceptable to smoke. Can you speak to that, the stigma of smoking? And then I'd like to hear too what you're offering patients to help them quit smoking.
Yeah, I think that that's a real concern, and my hope would certainly be that that stigma or perceived stigma isn't a barrier to trying to quit smoking. I hope that folks, particularly within the MUSC health system, if you reach out to a provider to talk about quitting smoking or engage with our MUSC tobacco treatment program, I think that you will find a very welcoming response from our providers. And really, I feel this way. I'm sure Dr. Tanner feels this way, and everyone here. We just want to meet you where you are and help you to improve health, like you said earlier. And I think the resources are here for you, and you can quit. And there's a lot of support here to help you with that and to sort of help you all along the way. We know that it's sort of not a smooth path to quitting smoking. A lot of people will try multiple times and sort of recycle through that, and that's fine. That's totally normal. You're gaining experience. You're learning what works and what doesn't work to ultimately sort of get to the point of quitting smoking. And so folks here at MUSC are really here for you to help you with those quit attempts.
That's great. I don't treat lung cancer. I treat other types of cancer. And so trying to understand how to have that conversation with patients, when they're walking into my office and they have a new cancer diagnosis and they're a smoker, that's maybe the way that they're dealing with the stress and anxiety of this new cancer diagnosis. So how do you address that?
Yeah, absolutely. And, even beyond just sort of the stress of a cancer diagnosis, we know that things like low mood, depression, symptoms of anxiety, boredom, frustration, anger are risk factors for starting to smoke and for continuing to smoke. And I think that there are strategies out there that are evidence-based that can help sort of target those symptoms of low mood, symptoms of anxiety to give folks other resources to lean on when you're trying to quit smoking to help you have more success with it. And so I think there are other tools out there to help, and we certainly are understanding that it's complex and there's a lot of stress there, and that oftentimes smoking can serve as a stress reducer, and we want to help to find other tools in those moments.
Yeah, great point. And we should talk about vaping, right? That's not a healthy alternative to traditional cigarette smoking. And we're still finding out more about the long-term effects of e-cigarettes. I understand that just last month, the National Institute of Health published 2 studies about how e-cigarettes can damage blood vessels. And Dr. Dane, you've done some research as well, looking at how telehealth could maybe help young people quit smoking. You want to talk about that?
Yeah, so certainly when we think about younger people that are vaping, we certainly don't consider that something that would be healthy. It's particularly concerning, and so I'm leading a grant from the National Institute on Drug Abuse to think about how do we develop accessible treatments that can help younger folks between the ages of 16 and 20 quit vaping. And so exactly with what we were sort of just talking about with these low mood symptoms that can contribute to smoking, make it more difficult to quit smoking, we see that same sort of pattern earlier in life, such that symptoms of depression are sort of placing younger people at risk for starting to vape, and then make it difficult to stop vaping when you want to stop vaping. And actually, our group, which was led by Dr. Tracy Smith, who's also a Hollings Cancer Center member, published a paper recently in JAMA Pediatrics that found that about 50% of younger people that are vaping want to quit. Many have tried to quit and have not had success. and that those symptoms of depression and symptoms of anxiety are highly prevalent among these adolescents and older adolescents that are vaping, want to quit vaping, have tried and have not had success. So this intervention that we've developed is called VapeX. It's actually available to anyone on the iOS or Android App Store now. The framework for it is trying to use evidence-based tools to treat and target those symptoms of low mood in the service of promoting vaping cessation. And so we've developed the intervention, and we are in the midst of evaluating it right now in a fully remote clinical trial. So stay tuned for the results of that.
I can't wait. Dr. Tanner, for people that are listening, could you just speak for a moment about what are the harmful effects of vaping? Because, it doesn't have the tar in it. So what is it exactly that's doing the damage?
Sure, I think we're learning a lot about that. It has a lot to do, in some cases, with the flavors that are added, the voltage of the batteries that are used to vape. And so it was kind of a big thing prior to, COVID and the whole pandemic. We were seeing a lot of vaping-induced lung injury in adults and pediatric patients alike, with what really just resembled very bad lung injury requiring, being put on a breathing machine. And so I don't think we've unpacked all that there is behind vaping-induced lung injury. Certainly there are certain types of devices to deliver it that have been adulterated and other types of things put in, cannabis type CBD oils and all of these types of things, and it's really just hard to know what you're getting in there, right? And so I think we continue to learn, but there's definitely a risk for lung injury and potential hospitalizations that haven't quite been realized.
And I would say I think there's a nuanced story here where when we think about younger people, vaping certainly isn't safe. We would never want to encourage vaping among younger people. I think when we think about adults who are smoking cigarettes, there are perhaps more considerations. So we know that cigarette smoking is not safe. And that many people perhaps try to quit and fail. And so I think things like e-cigarettes can be considered in sort of a harm reduction framework, where if someone can't quit smoking and has tried through all the standard methods, vaping certainly is not safe, but perhaps might be safer than continuing to smoke. And that's sort of an important line of research now, but something to consider in terms of thinking about younger people versus established cigarette smokers.
Yeah, I think that's a really important point. Certainly we don't want electronic cigarettes and vaping to be the gateway for our, middle school children to start smoking combustible cigarettes. But, when I have someone, and I often have lots of folks that come in to see me because they are smoking cigarettes and have lung-related injury to that, they'll ask me, what do you think about vaping? And it's a very nuanced conversation, right? And so I think if you use it as a means to, as you say, harm reduction, to back away from the combustible cigarettes, and use it as a way to help you quit smoking, then it's a conceivable option. It's kind of a slippery slope, and I always advise them about all of the other nicotine replacements. We have even nasal sprays with nicotine in them to help with the cravings, and certainly other medicines that we know help with the cravings. And so I always try to push those first. But some people are kind of bent on that e-cigarette piece, and if they're using it as a means to stop smoking combustible cigarettes, I have a little bit more tolerance for that than I would a junior high student picking it up for the first time.
Of course, and then I think the message can be, if you're going to switch completely, right, from combustible cigarettes to e-cigarettes.
Thank you. So that's been a tremendous help for me in understanding the screening and who should be getting screened, and that it needs to happen every year. Is there anything else we haven't touched on today that's important for our audience to know?
Well, I just have one little thing, not to go and done. No. So I think it's really important for our audience to know that the uptake of lung screening has been much lower than the uptake of traditionally screened for cancers. And so why is it that the uptake of lung screening is so much lower? We're at 4% nationally compared to breast cancer screening, where rates are so much higher. And I think it's because of this stigma that you talked about earlier. And there's a sense of fatalism amongst some people that smoke cigarettes, thinking that they deserve it. And I think the message here is that we, as a healthcare community, as a health system, as physicians and providers that take care of people that smoke cigarettes, is that no one's here to blame. We're not trying to associate a stigma with it. And we would encourage everyone that's currently smoking or previously smoked in the past to really consider taking their health into their own hands and not dwelling on, oh, this could be my fault. So too, there's a population of patients who develop lung cancer who have never smoked. And I think sometimes that group can kind of struggle with being, tagged. I think we need to stop tagging people for bad health behaviors. There are many decisions we all make in life, and some of them are harder to get out from under. And so I think my last words would be that, we care about you. We want the best for your well-being, and no one's here to attach a label.
What a great message. We're going to put some information up about resources that are available here at Hollings Cancer Center. If you're ready to quit smoking, you can call the MUSC Health Tobacco Treatment Program at 843-792-9101 or the South Carolina Tobacco Quit Line at 1-800-QUIT-NOW. If you're interested in lung cancer screening and you are ages 50 to 77 and a current smoker, or you quit in the last 15 years and you have a 20-pack year history, that means a pack a day for 20 years or 2 packs a day for 10 years, then you are eligible for lung cancer screening. You can contact the MUSC location nearest to you to set up an appointment with one of our nurse practitioners. And you do not need a doctor's referral to set up one of these appointments. The nurse practitioners will sit down with you to make sure that you're eligible and walk you through the risks and benefits of screening. Thank you for tuning in to Hollings Crosstalk. This is where we connect with the community to share news that is changing what's possible. If this is your first time watching, make sure to go to our multimedia page to watch past episodes and check out the Hollings news page for our latest updates.